Thank you so much, Kavya. And at the outset, I would like to thank Somshila and the All India Ophthalmics Society Scientific Committee for inviting me for this wonderful session. And Kavya, can you see my screen?
Yes, Dr. Jagadesh, your slides are visible.
Yeah, thank you so much. So in this next 8 to 9 minutes, I'll be talking to you all on to link or not to link and challenges in assessment of keratoconus progression. So the objectives of this class would be understanding progression of keratoconus and the current lacunae involved in it, and do we cross-link all keratoconus patients with a few examples. So as we all know that keratoconus is an ectatic corneal condition which is progressive in nature, and this could lead to very severe ectasia, leading to high drops in a few situations and corneal scarring, and finally increasing the need for keratoplasty when the vision is very poor. So if we identify this earlier, so we could do a lot of benefit to the patients. So this study that came up recently has shown that by identifying progression at an earlier stage and cross-linking patients would save not only for the patients, but entire economy as well, wherein the loss would be decreased significantly. So when you look at the parameters that are used for predicting progression, we use several parameters have been used over the years. So a progressive increase, steep or flat keratometry, mean keratometry, or maximum keratometry, or change in spherical equivalent or astigmatism, or a progressive decrease in thinness pachymetry or corrective distance visual acuity. So all these have been used in the previously to label a patient as having a progressive keratoconus. When we look at this study, it's a meta-analysis that's been recently published, and it has looked at, it has shown that majority of the studies have shown Kmax as an indicator for progressive keratoconus. But when we look at all these studies in the meta-analysis, there's a lot of variability in the ethnicity, age, and baseline Kmax values that can influence a decision that is made whether the keratoconus is progressive or not. So there's a lot of heterogeneity in the Kmax that has been studied so far. Similarly, when you look at mean keratometry, this also shows a lot of heterogeneity in all the studies when we compare all these studies. And it has been shown that Pentacam showed a steeper keratometry compared to OpScan in the studies that have been published. And it's also important for us to look at the repeatability of each machine that we use. So all these studies have been looking at Pentacam as one of the device. And if you look at the correlation is very good among these, but if you look at the repeatability of these instruments of all the steep keratometry, flat, thickness, and Kmax, there's significant variability among these. So we cannot consider one single parameter as a guideline for us to identify progression in keratoconus. And this recent study has looked at good correlation among the parameters, among different grades. And on to the right of your screen, if you look at the repeatability, there is significant variation in the repeatability of the measurements in different grades of keratoconus among steep keratometry, flat keratometry, and the maximum keratometry. I think it's very important for you to remember these variabilities when you want to label a patient to be having progressive form of a disease. And when we look at the studies, a few studies have looked at one diopter as a cutoff for a year, and a few studies have taken as 6 months as a cutoff value. And if you look at the thickness variability, I think some studies have taken 20 microns, some have taken a 10 micron decrease, and a study has taken 5% decrease in the thickness. So there's a lot of variability if you want to consider one single parameter as a guideline. So, and the global consensus has definitely shown a lacunae in identifying progressive form of keratoconus, and they did come up with saying that at least 2 of the anterior, posterior, or corneal thickness changes should be identified before labeling a patient of having a progressive form of a disease. But if you look at only the ABCD classification from the Pentacam, has ability to look at different maps and then give you overview of these comparisons. But this is not this is specific to users of Pentacam and not to generally available in other devices. So as of today, you see a topography being available in even with general ophthalmologists, and we do see a lot of collagen cross-linking procedures being done by general ophthalmologists. So their criteria is most commonly looking at K1, steep K or flat K, and looking at the difference between these two, and also decrease in the tachymetry. When we look at this, if you have a central keratoconus and if there is progression, it's very straightforward thing for you to detect progression. So here, the change in keratometry, steep keratometry, is a clear indication that you want to do a collagen cross-linking. But we do have situations wherein this is a patient who had, this is a dual Scheimpflug imaging system, wherein you see a patient having keratoconus in one eye, and the other eye shows this picture. And then 3 months later, you definitely see change in the color pattern and also values in the localized area, definitely suggesting a change in the indices. But if you look at the commonly used indices, there's not much change in the steep or flat keratometry and the mean keratometry. But if you look at the other eye, there's a significant progression and patient underwent collagen cross-linking. So our aim is to pick up early progression in cases like we saw in the former example. So then we came up with this study wherein we wanted to use color images that could predict progression, and this could be available for any device and not specific to one single device. So we came up with this study to look at early detection of early progression using deep learning convolution neural networks. These are our collaborators here. So this was the objective that we came up with this study. We included all those patients who had multiple visits, and we excluded patients who had any of the corneal conditions that could affect the topography or tomography. So we defined progression as change in flat and steep keratometry of greater than or equal to 1 diopter, and we labeled a term called latent progression, which is the progression detected by this model. So I'll run quickly through this example, this study. So here we did image acquisition. We removed all the values from the images, and then we looked at the images in this format. And then we looked at 351 images, both normal and keratoconus, and we built models. And finally, the testing was done with 1351 eyes. So we divided these images into 4 based on sagittal curvature, anterior elevation, posterior elevation, the pachymetry maps. And then we compared between 2 visits, each of these. So similar, and we compared in multiple visits and looked at which visit we did identify progression. So there were 1351 eyes included in the study, and we did see that in overall, this model was detecting progression at least 11 months earlier than change in the steep or flat keratometry. And this was irrespective of age of the patients and gender of the patients. And irrespective of presence or absence of allergy, this model was predicting progression early, but it was more earlier in patients who had allergy. And also, like, we did see earlier prediction of progression in patients who had worse visual acuity, but it was detecting in all cases. And similar trend was seen with all the spherical equivalents, and also amount of astigmatism that was seen in these patients. In a nutshell, if you see, at least 43% of patients had detection of keratoconus progression earlier in this model compared to K1, K2 change in the first 6 months, and it was about 60% of them in the first 12 months. So I think identifying subtle changes would be a game changer. So artificial intelligence and deep learning would help augment our clinical judgment. So do you have a minute to show an example, Dr. Nikhil?
Yes, sure, please.
Yeah, so this
You're
is
in good time.
Yeah, sure. Thank you. So this is a patient who presented to us with this picture. This is a 11-year-old male with a history of allergy. You can see on the right eye, this is an op scan showing on the sagittal curvature an asymmetric bow tie with inferior steepening. Left eye looks pretty okay, except for some amount of posterior elevation and a skewing in the anterior sagittal curvature. And this patient was followed up with us, and then he was lost to follow for 5 years, and then he presented to us with this picture. And this is an oculizer that we had documented at this point of time. Definitely you can see, compared to the previous scan, there is more steepening in this eye, in the right eye. And if you look at the left eye, definitely there is a significant increase in the steepening and also change in the pachymetry as well. But these two devices were different. So we, at this point of time, we did discuss with the patient about the possibility of collagen cross-linking and explain the lacunae in comparing these two devices. And then the patient didn't want to get any intervention, and then he followed up subsequently. So after the second visit, and then he was followed up again subsequently. And this is after 6 months of the second visit. And here we do see pretty much similar amount of change in the keratometry. And if you look at the difference maps, there's not much change in the right eye that we noticed. And if you look at the left eye, there are subtle changes that we did notice. And when we look here, the keratometry, steep or flat keratometry, you don't see much change here. When you look at localized in the area of cone, we do see some amount of steepening in the local area. And for everybody to understand, I just summarize everything here for this patient. So on the top 3 rows, you have the right eye, and the bottom 3 rows, you have the left eye. When patient presented to us at the first visit, he had eye rubbing, and these were the keratometry values here. And when he presented to the second visit after 5 years, we do see increase in the astigmatism and some amount of myopic component. And this was the keratometry values that we noticed. And he followed up for 6 months again, and we did see a change in the myopic component of the refraction, but the cylindrical component was pretty much stable, and the keratometries were stable. Do we cross-link this patient is a question. So because he has been progressing when he had eye rubbing, and then after that, when the eye was very quiet, and the topographies were pretty stable. So we did observe this patient, though we didn't do any collagen cross-linking. So there can always be a debate, why shouldn't we cross-link such patients when we see them at the first visit? And this is the left eye of the patient, where we did see, when he presented after 5 years, a significant change in the refractive error, and also increase in the values compared to the OP scan. But this patient didn't want any intervention.
Dr. Jagadesh, but may I please request you to sum it up in 30 seconds?
Absolutely. Thank you. So on the third visit, when we look at this patient, we did see a slight increase in the keratometry steep K, and the flat K was stable, and a diopter change in the K max. So with the repeatability of the machines being variable, I think it's very important for us to take a call when we want to label a patient with a progression and keratoconus. Okay, and I'll skip these. I think it's very important for us to look at other parameters as well apart from topography. So it has been shown that there are several parameters that could affect the progression form of keratoconus. I think it's important for us to ask type of rubbing, nighttime work, dry eye disease, sleeping position. I think these are the factors that play a huge role in the mechanical component for disease to be detected or a progression to be detected. Okay, so I'll skip these examples and then summarize. I think there are a lot of unknown factors affecting the pathogenesis of onset of keratoconus and progression as of today. In the current scenario, mechanical component appears to be playing a major role. Awareness about eye manipulation and treating ocular surface inflammation would help in preventing further progression of the disease. So higher preference for collagen cross-linking should be reserved for patients with reduced compliance with the above management strategies and people who have persistent unconscious eye manipulations like children with associated syndromes. And variability in decision-making would continue until more evidence on these concepts is published. So this is what I have.